feasibility of using artificial intelligence in clinical medicine, knowing that there's a lot of hype at the moment, and there are a few implementations in the US and around the world. So what do we know to date? Down, okay. I do have some disclosures. I consult for some companies. Some of them are AI companies, medical advisory board for an AI company, and have started 2 companies. One of them is an AI startup. And of course, I'll disclose that I'm not an oncologist, but a pathologist. So I'm the chair of pathology at the University of Pittsburgh, and these are some of the unmet needs that I am trying to address. And I hear complaints every day of how busy people are with their workload, how complicated things have become, oncologists asking for more and more tests, more ancillary studies, more molecular testing, just not enough people. There are not enough pathologists, there are not enough technologists, so definitely a workforce shortage. Yet the advances in medicine haven't stopped. People looking for new biomarkers, new testing, and they want this all quantified. It's very hard for a pathologist to go to HER2 low. How low can we go? So it makes a difference. And people are still telling me that they burnt out despite the fact that COVID is no longer officially a pandemic. So obviously, I need to look at technology to solve that. Yes, faculty, staff are all concerned that I'm bringing in computers and technology to replace them, and we can discuss that at some point during the talk or afterwards. But the point is, can technology solve these issues? I don't know if anyone has been into a high-rise building, I guess in the last 10, 20, 30 years, and you've seen an elevator operator. But I'd like to just briefly for a minute tell you the story of elevator operators, which is the exact analogy where we are now in healthcare. So when elevators were invented many years ago, people were afraid of the technology. They didn't want to go into them, and fairly so, because they were quite complicated, many things to push, many things to operate in an elevator. And so that's when elevator operators came about, and they did that for you. But as the technology improved, there was really not much an elevator operator needed to do. They were very important. In fact, they needed a license to be an elevator operator. But as the technology improved, all they really did was accompany the passenger to the floor that they needed to get off on. I'm not sure what that's okay. But then 2 things changed. Number one is elevator operators went on strike. They didn't get paid enough. So there were not enough of them. There was definitely a workforce shortage. And during all this time, the buildings had become so high, New York, Chicago, even Cincinnati, that no one wanted to take the stairs anymore. So as a result, increasing workload, no workforce to address that, they had to trust the technology. And by the time they got onto an elevator, the technology was just fine. So are we at that point now in healthcare? I do believe we are. There is AI from the womb to the tomb. I didn't make that term. That's Eric Topol from Scripps. It's true that there's AI to select embryos, the time of IVF. You can predict who out there will land up in hospital. You can predict when someone's in hospital who's going to land up in ICU. And there were over 200,000 AI algorithms built during COVID, even who would die. We don't use virtually any of those AI algorithms today, of those 200,000+ that were developed during COVID, because they're not practical, they're not generalizable, and most of the algorithms didn't even have a physician around to participate in that development process. So I recently looked up in my own field, computational pathology. Computational pathology, yes, means computers in pathology or computers in medicine, but the definition truly of computational pathology, and you could say computational medicine, means taking multiple sources of data, analyzing those large data sets, combining all those data sets, multimodal, and then using it to make a decision. That's what we do anyway in practice, multidisciplinary practice. Oncologists, pathologists, radiation oncologists, radiologists, we all get together, multimodal modalities, multidisciplinary, and make an informed decision. And that's where we've reached that point with AI today. You can see how many articles there are, even to the right, how many cancer-based articles today are using AI to even study cancer, the tumor microenvironment, the relationship of TILs, and so forth. You can no longer do that with a microscope. I know, because I don't do my research using a microscope anymore. I've put away my microscope to do that kind of research 10 years ago. So how am I supposed to participate in clinical trials, response to therapy, etc.? I do need technology. So under the umbrella of artificial intelligence, there are many different types of AI, and the field has advanced because of the advances in technology. We have high-performance computing, advanced techniques to do programming, and so forth. AI is basically having a computer think like a human with narrow tasks, not very broad tasks. Then within that umbrella is machine learning. Machine learning is simply programming a computer to look at large data sets. But when you have very large data sets, to look at those trends, you need deep learning, which is basically processing the data through neurons like you do in the brain. That's deep learning. And all of those steps, AI, machine learning, and deep learning, involve real-world data. That's traditional AI. We're in the era now of generative AI, where we are using AI with fake data. That's like ChatGPT, and I'll show you some applications in healthcare today. Now, AI, for those of you who've looked under the hood, it's not really as big a black box as they make it out to be. It's very mathematical, lots of calculations based on probabilities and predictions. If you look at the output, it's very mathematical. So I work with a lot of AI programmers and PhD data scientists, and the data is all numbers, numerical, quantitative. And as a pathologist, I definitely like things dummied down to me and shown in a morphology or another way to be able to make a decision, which is what we call explainable AI. And the good thing for all of us in healthcare is those folks making AI for us, they're aware that none of us, oncologists, radiologists, want to look at quantitative data. We weren't trained to be data scientists. We don't want to be data scientists. We want to be physicians. So they're dumbing down the data in a way, appropriately. Here's two examples. So on the left is prostate cancer. If I was looking at prostate core needle biopsies and I got a report from the AI that told me this GPS location on the slide with this probability of these particular glands and those pixels being cancer, it's too quantitative. I prefer, show me where the cancer is, put a heat map in that location, and if the glands are a high probability of being malignant, then make it red. They're low probability, change it to a blue color. I can understand that, that's explainable. Or on the right, if I have to screen a pap test, I don't want to look at 200,000 cells and then you give me a report where it tells me how many cells, and these are the cells that rank the highest with this probability, and the features they rank the highest were because the cells have this percentage high nuclear cytoplasmic ratio. It's too quantitative. Just find me the worst cells, rank them from the worst to the lowest, and show me the top 30 worst cells in a gallery like that, and I can make an interpretation. And that's applicable to all of AI in healthcare, especially those that rely on imaging disciplines. So here's some examples of AI applied to radiology with that premise. So on the top, if you were looking at chest x-rays at your institution and you didn't want to miss a pneumothorax, let the AI screen all of those, and then when it finds the pneumothorax, triage those. So they're first on the list for anyone radiologist to look at. We're running something like that now at UPMC in Pittsburgh. The other is, instead of just finding the cases, show me where in the case is the abnormality. Show me and sort of screen that for me. So AI can do that, looking for lung nodules or breast masses in mammograms. Show the end user where the abnormality is. That's very easy to do, and you can see it did that for the lung mass. Or more than that, once you find the case and you can localize where the abnormality is, segment that out in the image, then take the features that are important to me. What's the size? How bad is it? Is it malignant? Is there infiltration? Is it spiculated calcifications? And present that to the physician. And so AI is able to do that easily today. These are some of the things that are applicable to me in my field. When I'm looking at a slide, I'm looking for, a needle in a haystack often. I mean, if you want to know if I have a biopsy of a breast cord, that I don't miss the microinvasive area, well, pathologists do miss that. And so maybe I can find those rare areas of cancer invasion or a rare organism or something that will change the way you treat your patient. And then you want me to count things. How many mitoses? How low is the Ki-67? I will bet you that if you give 100 pathologists something to score, grade, count, you're going to get 100 different answers. Okay. But because of the deep learning, we were able to even make a diagnosis. Find me that cancer. Is it adenocarcinoma versus squamous? What's the grade? Is there lymphatic vessel invasion? And so on. We can even make a prognosis. If I train the AI algorithm not to just make a diagnosis, but to some outcome, will this patient respond to therapy or not? I can do that. And then finally, what's most exciting for me is, as an academic pathologist, I like to use AI to do my research, which is the premise for biomarker research with pharma, clinical trials, measuring endpoints. I don't think we can do that with humans reliably anymore. So if this was one of your patient's biopsies of a breast mass that you sent me, these glands are quite well differentiated. An average pathologist looking at this very quickly may think these are normal glands, but if you stop, could this be a tubular carcinoma? They're a little abnormal, cribriform. The AI algorithm had no problem finding that. Okay, so easily detect that. And that's what people want. Don't overcall or undercall anything. But it can do more than just that. Yeah, it's looking for lymphatic vessel invasion. So we're beyond the point where an algorithm just does one thing. They can do multiple algorithms simultaneously with the high performance computing we have. So find me the LVI, lymphatic vessel invasion. Find me the tumor infiltrating lymphocytes and quantify that. And so whatever medicine now presents to me, Liron, you have to do this as a pathologist. You have to add this as a pathologist, measure this, count this. What's the relationship? How far are the lymphocytes from the tumor cells? If that ever is going to become a thing, I can do that now reliably. So here's an example of it's easier than it looks. I got tired of looking for mycobacteria in slides. They're these tiny little microorganisms, microscopic, and I have to screen a slide for a patient that's suspected of having TB, transplant patients, immunosuppressed cancer patients. And many times we miss those. I know because I have a resident and a fellow. They're my real-world AI algorithm. They screen it, they miss it, and then I look at it and I find it. And so I got tired of doing that, and so I built a homegrown algorithm which runs at UPMC now. It's been running for 5 years. Anytime someone orders an acid-fast stain, the AI algorithm screens it, finds the bugs. And you can see the website on the left has a gallery. Very easy for a pathologist. All I need is one image, there's the mycobacteria, and I agree. 6 months ago, I did a survey to ask all the pathologists, who's using it, and if you're not, why are you not using it? So it turns out 1/3 of the pathologists, and I have a department of over 100 pathologists, 1/3 use it all the time. They don't even wait for the glass slide. They trust the AI, and they sign out the case, TB or no TB. That's the question. The other 1/3 look at the AI, but they wait for a glass slide to be sent to them just to confirm under the microscope. There's only been one discrepant case, and it was that the pathologist was wrong, not the AI. And then 1/3 do not use this at all. And when I asked them why don't they use it, is it that they don't trust the AI? The answer was no, because the AI is a separate standalone system. They have to remember to log in with a password, and it's not integrated in their workflow. So it's just simply inconvenient. So if AI has to be successful, whether you're an oncologist, radiologist, cardiologist, you have to integrate it into a digital ecosystem. And what is that ecosystem we practice? Whether you're in a private practice, hospital-based, or a huge integrated healthcare network. Your lab information system or electronic medical record, where most of your patient data resides, has to be linked to your imaging system, your PAC system, lab information, your image management system, or whatever cardiology or whatever ology is using, echoes, endoscopy images, and then you add your AI. Now, they all have to be integrated. The problem is, again, it's harder than it sounds, because I'm running AI algorithms as a pathologist, and I speak to my radiology colleagues. They're also running about 11 plus algorithms at UPMC every day. But none of us are running them the same way. So some of them I'm running with the images going to UPMC's own intranet on our own cloud, and they analyze that way. Others are run what was called edge computing. Wherever the device is, the AI is on the device and it runs there. And then I have an option where the AI requires me to push the image outside of our network into the vendor's cloud, some rented AWS space, which is HIPAA compliant. So we don't have a good way of doing that now, which is driving my CMIO and CIO crazy. And these all have to talk together. As I said, my pathologists don't use it because it's inconvenient, not because they don't trust it. We're all using different images, and once you start having proprietary images and proprietary algorithms, nothing becomes standardized. Now, if you add on another hospital or you have another group in another state, then no one's compatible because you all have these proprietary systems in place. And you really have to go fully digital. One of the problems I have is these hybrid workflows. What's harder for pathologists to accept with digital and AI is going paperless. Doctors love paper. But if you're digital and using AI, then they want to write down the AI result on a piece of paper or whatever. And so if I take the paper away, that's the hardest part. So it's a lot of change management. And one of the things I found working with a lot of AI algorithms and companies is they'll say, yes, our AI works with Epic, no problem. But when you plug it into Epic, you lose all the wonderful bells and whistles and functionality. So, who's going to do the work? Is it Epic? Is it the AI companies? And so forth. And the other thing I've run into is our system we have a lot of IT analysts in our IT system, but I've asked for analysts to deal with AI, and they don't have anyone. There isn't even a job description for an IT analyst who focuses on AI. So, they've given me an imaging person or a server person, and that's really a problem. So I took a random flow diagram from a radiology paper just to show you what's involved in going from sort of bench side to bedside for AI. So let's start at the top left. You need a lot of data to have a good algorithm, and that's probably the hardest part, the bottleneck, getting all the correct data annotated, labeled, etc. And then you train your algorithm, and one of the things a lot of people struggle with is what's the ground truth? So I don't know, is the ground truth a human diagnosis, a molecular result? Well, not everything gets tested with molecular, especially benign. So there's a lot of bias involved. But nevertheless, once we have an algorithm, you have to verify that. In other words, if you're given an algorithm to use in your environment, will it actually work in your environment? Run on your images, run on your EKGs. It may not be generalizable. And then to get your answer. But before you actually use it on patients, you're supposed to validate it. The lab is a very regulated place, so we have to do things. Joint Commission can inspect us, the College of American Pathologists, etc. So we're good at documenting that. But I've seen places where people plug in an AI algorithm and they haven't really validated it. And I'll tell you what I mean by validation in a minute. One of the other things to think about is where in your workflow would you insert the AI algorithm? So let's take this workflow. On the left, you have slides and you digitize them. You have a pathologist who looks at them, and then he issues a report. It could be a radiologist, it could be a cardiologist, etc. If you put the AI before the physician, well, some people call that a first read. The AI can screen. If something's out of focus or not right, can repeat the test. You can order the test. You can triage it. You can even issue a report. I talk about that as a digital fellow or digital resident. Today I have a resident and a fellow. It takes me a year to train them, and then they graduate and I have to start all over. With AI, once I train the AI algorithm and it adapts, it just gets better. It's not going to graduate at the end of the year. This is where people have a concern, because if it's a negative case, do you need a human then to look at it or not? I do believe in a human in the loop, and I'll show you an example why. Or you could have the human look at the case and then direct the AI to do something for me. Can you confirm the diagnosis? Can you check the score? Can you do the grading or whatever you need? The top little AI bot I have there, no one cares about. I care about that a lot. Is AI running in the background to do all the QA stuff we have? Me as the pathologist, my chair of radiology, we spend so much time and money and people to do QA, like mammography and pathology correlation. We have to have a mammography in a cancer center that's compliant. But it's all manual. So why are we not doing mammograms and pathology, path-rad correlation, and many other correlations all done by AI in the background? I don't know. But I will tell you that the most important thing is garbage in is garbage out. You don't train well, you don't have good data, the output's going to be garbage too. So here's an example of a breast core needle biopsy. It's a picture of a slide. There's breast cancer with a lot of fat on it, and it was stained with HER2. You don't see the brown HER2 cancer because it's a HER2 zero case, so there's no real brown staining, maybe today HER2 low. But the score should have been 0, yet when we ran this, the algorithm counted it as 3+, okay? And why did it do that? Because there were air bubbles on the slide, and the air bubbles got counted as complete membranous staining. So a lot of air bubbles, a lot of membranous staining, turned it into a 3+. Now, how do you avoid problems like that? Well, oops, sorry about that. So number one is make sure you have good data to train. A lot of artifacts, etc. A lot of people are worried about collecting perfect data to go into your algorithms. But you actually need heterogeneous data, which is unbiased and has artifacts. You need to validate it, and this is why you need a human in the loop. No one is caring, or they don't know how yet, to even monitor algorithms when they're in use. Are they going to deteriorate? Do we do proficiency testing on them? Or how do we monitor them? For now, we monitor them when a human says, oh, something's wrong. But we don't really monitor the coefficient of variation. So I've had lots of arguments with colleagues and vendors is, well, how do you validate an AI tool before you actually use it on patients? The companies will tell you on the left, analytical validation. That's what they have to do. Lots of cases, hundreds or thousands of cases. They have to do that kind of validation to make sure that the algorithm performs well and even maybe show it to the FDA. That's too much work for us, not necessary. But it's also not good to just have technical verification, which is the vendor will say, give me 10 or 20 of your cases, I'll run the AI, we'll check that it works for your institution and your practice. That's like if you want to buy a car going into a car dealership and the salesperson telling you, yeah, look, it's got cruise control and the windows are electric and you go, I love this, right? What you need to do is test drive it, like on the right. You need to test drive it for exactly how you want to use it in your environment. So if you're going to take it and use it off the road, then that's how you need to test it. At least not as many cases as are required to get clearance from the FDA, and not as many or as few as you need just to verify it. But there are no guidelines, certainly not in my field, and I'm not aware of others, for healthcare guidelines on how we're supposed to validate this. So 5 years ago, I told our pathologist, prostate core needle biopsies done at our cancer center are all going to be screened by AI. And then the question is, how do we validate it? There were no guidelines. So what I told them is we'll take 3,000 slides. That's 100 patients who are diagnosed with prostate cancer. We'll take retrospective cases with 3,000 slides. They were already diagnosed by a subspecialty GU pathologist. All they do is look at prostate core needle biopsies every day. And then we'll have the AI run and check those. And so there were 30 slides where there was a discrepancy. The AI and the MD didn't agree. And of course, my GU pathologist said, you see, that's why you need us. And so I said, well, let's first adjudicate those discrepancies. So we gave them to another GU pathologist to check them. We had a consensus, and we stained all those cases with immunohistochemistry to confirm perineural evasion, etc. And for all 30 cases, the AI was correct. Okay. Here's a case. This was called negative. However, the AI highlighted that area, and it was 3 + 3, and we confirmed that. Now, when I spoke to the chair of urology, the chair of urology was super happy we were using AI, Not because he didn't trust the pathologists, he thought they were pretty good for accuracy, but because every time his patient with prostate cancer came back, he looked at the name of the pathologist at the bottom of the report because he knew, oh, they're a heavy-handed Gleason grader. I know what to do next, or they were not. So he liked the standardization. Then I gave all the pathologists the same yardstick to practice. And so that helped standardize our practice. Now, I've come to realize that the same AI tool in a different hospital or different practice has different functionality. At UPMC, we have 40 hospitals. Some are academic and some are not. They're more community-based. For the academic hospitals, where my academic pathologists are, they have a moderate workload, but fairly complicated, and that's why they're subspecialists. They get upset when I tell them to use AI because they're quite insulted, telling me, are you giving me AI to check the accuracy? You know, Dr. Pantanowitz, I'm the world expert, and people send me their consults for second opinion. But what they do want is time to do the academic work. So they want the efficiency. My community pathologists want something completely different from the exact same algorithm. They're generalists, so they don't see as many of the specialty cases, and they're more common community cases. They may see 5 prostate cases a week, as opposed to the GU pathologists see 30 or 40 a day. But they want to go home at night knowing that their diagnosis was accurate, and I want them to do that because I don't want them to keep sending atypical cases to our academic folks and just overwhelm them with these cases that AI could have done. So push the expertise to the community. Now, I think we have it all wrong. We are making AI algorithms to copy physicians, to do what we do for the most part. And the commercial solutions are doing exactly that. Find me a pneumothorax. Find me prostate cancer. Humans can do that pretty well. Yeah, occasional cases fall through the cracks and get missed. What I really think we should be doing is training the AI to do things we cannot do. I cannot look at an image with a crystal ball and tell you just from the H&E image what the molecular findings are going to be. I cannot tell you what the 5-year survival is going to be, other than giving you a little bit of information about the grade. I certainly cannot tell you the response to certain therapies, and that's really what we need today. So imagine if this was a patient that came to me with a lung mass, and I had a core needle biopsy, and that's a well-differentiated adenocarcinoma. You, the oncologist, is going to say to me, please send it off for testing. You couldn't really care less about which subtype of adenocarcinoma it is, according to the WHO, but you more want to know what is the underlying molecular finding, so you can provide targeted therapy. So what's going to happen if I don't have enough tissue? Or I'm at a center where I cannot do it? Or the patient cannot afford to have it sent out to one of these big molecular companies? Well, then we're stuck, unless we train AI to make those predictions. So if I just annotated a representative area and at the click of a button said to AI, you've been trained on 1,000, 2,000 cases, what is the prediction that this has whatever targeted therapy this patient needs? These studies have been done, published, they're probably 10 years old now. So that's all available. I just took 2 papers to show you that we should be training AI algorithms not to do what we do, but to do what we cannot do, which is predictions, provide predictions for outcomes, prognosis. I took a random paper from radiology on the left, high-resolution CT scanning. I don't want to know if that's UIP, usual interstitial pneumonia or not. I want to know, is the patient going to be around in 5 years? Are they going to deteriorate? Are they going to need a lung transplant? How do I treat that patient? So you can make that prediction. Similarly, the same question to the paper on the right. Again, patients looking at their lung biopsies, so wedge resections. I don't want to know if this is what the pattern is. Yes, it's UIP or non-UIP. It's cancer or not cancer. I want to know, what's the survival? Is this patient going to respond or not? So that's what we can do with AI. Up until this point, we've been doing what's called unimodal AI. We've only stuck with one mode of AI. EKGs, apply AI. Images, apply AI. But we don't practice like that as physicians ourselves. As I mentioned earlier on, we practice in a multidisciplinary fashion. Oncologists, radiologists, radiation oncologists. pathologists all together. And so the field is moving to multimodal AI, where you take all the available data. If your system is smart enough to collect all the data and make it available, then apply AI to all that data, and then give you, in the right context, the right answers to the questions we need, which is what our patients deserve. Finally, we're in the era of generative AI. Generative AI is when AI can generate the data. It's not real-world data, it generates it, like ChatGPT. Most of you have probably worked with this transformer. So it can generate for you. Generate me text, write me a poem, create coding, whatever you want. Write my PhD thesis, and so forth. So it is being used in medicine. We are using it ourselves today at UPMC. We've built our own PIT GPT. I use it to generate pathology reports. I'm sick of writing letters of reference. Now I just add the person's CV, a couple of things, and writes me the letter of reference. Now, I'm not talking about uploading it to ChatGPT or Copilot, which is in the public space for everyone to see, and then I lose privacy and intellectual property. We've built it on premise, so it's very private, can run off your laptop. So there are concerns, of course, that the AI hallucinates, it's not always right, or people will use it maliciously. But here's an example. These are 4 images of colon adenocarcinoma. This is histopathology with an H&E stain. The glands on the left are normal. The glands on the right are abnormal, adenocarcinoma. And in between is inflammation and desmoplasia. So we use generative AI to generate fake images. Which one of these is real and which one is not? Or are they all real or are they all fake? I've shown this to more than 10 pathologists who've took time to study it, look for mitoses. No one has got it correct. Okay, so the answer is only that one is real. The others are completely fake. And so it even fooled pathologists. So why would I spend my time doing that? Well, the answer is, and this is what people are doing now, we cannot build AI algorithms with high enough performance unless we have enough data. And there isn't enough real-world data, especially for some of the rare diseases. Can you imagine if someone wants to build an AI algorithm to look for Castleman's disease and all the subtypes and their response to therapy? It will take you a lifetime and probably a huge amount of networking and money to get that. Or I can spend a day or two and generate tens of thousands of Castleman's disease cases, CT scans, pathology images, and combine it with some real-world data. And it's been shown in both radiology and pathology that by adding synthetic data, you can now increase the performance of the training. Not only training of physicians, by the way. So now when we have pathology residents come through our program, we don't have to rely on having every rare cancer in the world come through our door so we can train them. If it's not available in our teaching set, we'll just synthetically create it for them. And they cannot tell the difference. But we can train AI algorithms. By the way, this is what Elon Musk does. This is why he's one of the richest men in the world, is because he's used synthetic data in his companies to get to where he is using AI. And so have everyone else except healthcare. So we're now applying this to healthcare too. People often ask me these 5 questions, so I'll share them with you. I have my opinion, I don't know if they're right or not. People, especially the vendors, ask me, Liron, what's the killer app? What app does every pathologist need? Well, the truth is, they probably, if you want to replicate what a pathologist does, you need 1,000 algorithms so that I can look at any tissue in the body to look for any disease, lymphoma, carcinoma, melanoma, with any stain. So I come to work with 1,000 algorithms in my brain. If you want to replace me, that's what you need. Which is the one we all need? I don't know. I suppose the one that gets us home before 5 o'clock. The other thing is, what's the right evidence? What does it take to convince a doctor or anyone else in healthcare to use it? If the FDA approves it, is that good enough? If there are publications in JCO or elsewhere, is that good enough? Or if your colleagues are using it? So what will it take to prove that it's good enough for us? And then how do we pay for AI? The technology is expensive, and most people mistakenly assume that at some point, CMS or someone else, insurance companies, will pay for AI. Yes, I think there will be. There will be reimbursable billing codes. In pathology, we already have 13 billing codes for digital pathology. But the assumption is that you will get paid more. But if you poke the bear, CMS, beware. You may get paid less. Because if you tell CMS, I can do this quicker, cheaper, easier, then why would they pay you more to look at a chest x-ray if it takes you only a second now? So they may pay us less to do the work. How do you have trainees interact with AI? I told you at UPMC in Pittsburgh, 5 years ago, we deployed the prostate algorithm. And the GU group didn't want the residents and fellows to have exposure to it. Their argument to me was, we're going to de-skill these pathologists. They're not going to know how to screen it themselves. Yeah, I get that. When I go out for dinner and there's a complicated check that arrives and I have to calculate a tip and there's 3 parties involved, I need to take out my phone to do the calculation because I've de-skilled my brain to do math because it's available. And I get that argument. But the point is, we're doing them a disservice because these graduating physicians will have AI as part of their world, more so than us. And they need to know how to use it, what the limitations are, troubleshoot it, and guess what? They agreed, and we switched over a year ago, and I insisted the trainees use AI. And guess who the champions are in the department now? The residents and the fellows and the junior attendings that used it. When there's need for troubleshooting, who does research using AI, etc., it's all the trainees and junior faculty that were using AI. And then finally, there's a lot of ethics and regulations which I don't even want to go into. Now, I've shared these 2 links with you so you can keep abreast with the field. These are provided by the FDA. The first link tells you everything about machine learning and AI from a regulatory perspective. Do they consider software as a medical device? How do they want to regulate it? How do you deal with adaptive algorithms? In other words, when an algorithm's approved and it's locked down, but you put it in your hospital or your practice, it's going to learn from you, and you want it to adapt and get better and better. But do you have to go to the FDA for each upgrade or not? How do you deal with all of that? They explain that, and it's worthwhile keeping track of how, as they become informed, these regulatory bodies, how they change. And then finally, there's a long laundry list of all the AI tools out there in healthcare, and they keep adding the ones that get cleared. So if you're interested and you want to know in oncology which algorithms are available, which ones are FDA cleared, there's a catalog for you to keep track of. So that's the message I have for you, which is the message I tell my faculty, the message I tell my CEO at UPMC. I am not, well, number one, I don't suffer from the shiny object syndrome. I'm not just doing it because it's cool and we should try it. I'm doing it because it makes sense and it solves a lot of problems. But I'm not doing it to replace people. I'm just trying to augment what they do and make their jobs easier. So the people who are signing out PAP tests at UPMC, I've given them an AI system. And they love it because they can screw those screws into the wood every day, look for every PAP test for cancer, look for every prostate biopsy for cancer, or they can have a screwdriver to do their job. And so I think once they start using it, no one wants to give up the screwdriver. In fact, what happened to a colleague of mine is when the server went down for 3 days, no one wanted to sign out prostate biopsies until the server was back up and running. So I guess, once you drank the Kool-Aid. So as Darwin said, it's not the strongest of the species that survive, nor the most intelligent. It's the one that is most adaptable to change. So hopefully you can embrace AI, and thank you for your attention, everyone.
Thank you, Dr. Pantanowitz, for an excellent lecture on a very complicated topic. We'd like to open the floor to questions, please.
Yeah, I have a question. So it's fascinating. Great talk, by the way. I learned a lot. If a very large institution like MD Anderson said, we have 10,000 lung cancer cases that we treated over the last 5 years. We know their outcomes. We know how they did. Their path is here. Images are here. NGS data is here. How many cases would it take, by your estimation, to have a very good lung algorithm developed by AI?
So that's a great question, and one I've asked developers like Google. I've asked Google, how many cases do you need? And I've asked other software developers like Carnegie Mellon University, etc. The number they always gave me pre-generative AI, before we had fake data, was 10,000 cases. Okay. But the truth is, you don't really need that many, because you can take some of the data and you can augment it. So for example, if you have the CT scans, you can rotate them, you can change the color, the contrast, and it adds to the number of cases. And you can break down images or data into smaller data sets, which also multiplies the amount of data. So it turns out you need less and less than we did pre all this technology. But the number out there is 10,000.
Okay, thank you.
Thank you very much for the presentation, very comprehensive. I'm Rasha Salama, pathologist at St. Elizabeth. I'm curious, how can we trust an AI platform that is not interpretable or explainable to make clinical decision? Like you said, use it to give us information that we don't know, like predict molecular phenotype. So what if it's picking up artifact? Can you speak to that?
Yeah, so that is a great question. I think the best way to answer that is if you look at the outcomes, okay? And there haven't been too many of these studies, but there have been a few studies. So for example, just a simple machine learning algorithm to quantify ER/PR HER2 KR67. Many pathologists will tell you that they can do it just as well, probably quicker, and it works out fine. And many times they'll agree that the AI gave us the same answer. But there have been studies in places where they only use image analysis based on digital imaging, like the Nordic countries, Norway, Denmark, where everyone in the country has to use image analysis from a government federal directive. And what they've shown in those cases is it's not just precision and accuracy. Accuracy means they get the right answer. Precision means you get the right answer each time. But when they look at the outcomes, guess which patients do better when you measure that to outcomes? Like, well, what does the molecular finding show? What happens to those patients who are put in management pathways and they have outcomes that they measure? It's the ones that went through the digital image analysis pathway so that the outcomes were better. So I guess it takes time to trust the AI. But outcomes data will show us, that's the right way. Unfortunately, this is still quite nascent in healthcare. Not that AI is new, but actual deployments and that they've implemented and we're using it. So, and most people don't even share that information. So there isn't enough evidence out there to actually come up with sort of evidence-based standards of care and guidelines for us. In time, that will happen, I think. But the truth is, for that reason, I personally, at my own institution, have kept a human in the loop. So we're now moving to all pap tests screened by AI. I could tell the cytotechnologist that if it's negative, you don't have to look at it. If it's abnormal, look at it, then have a pathologist check it. But I've kept, for now, a human in the loop because I'm not sure we know enough and have enough evidence. And it's for the same reason that when I flew to Cincinnati from Pittsburgh, the pilot in the cockpit wasn't doing much, to be honest. It was all computer-driven, etc. But I was happy to see a human up there, just in case something went wrong. Yes, I'm happy there's technology, so we could fly you and get you correctly, but what if it went wrong? I would still like a human in the cockpit. Now, I may be wrong, and I'll tell you where there are areas where people have argued with me that that's not the right way, and it's not possible in all situations. So I work closely with a physician who's the head of military medicine at UPMC, and he explained to me that for most of what he does with AI, there's no way to have a human in the loop, because it could be a soldier who's in a zone where if you go into that zone, you will get shot or blown up or die. So there's no human in the loop. It's the AI that's sent out there making whatever decisions, operating or doing procedures. So yes, that's a different scenario. So if you see your routine daily practice as being, part of a battle zone, then yes. But I think we have to wait for more evidence and more people to share the evidence to be 100% certain about trusting the AI.
Thank you.
You mentioned the de-skilling, and actually it's a major concern. And I know eventually everybody will get used to it, but when you mention the system is down, then they could not do work. So now the pathologists you are going to graduate, let's say they go to a lower resource hospital, can they do the work? Can they actually do the work in another hospital, not UPMC, if they don't have access to the same toys?
Well, that's why I do the AI, so they only want to come work for me. It's part of my retention policy. No, it's actually interesting. So I'll answer your question, but just to let you know, the fact that our Department of Pathology is very savvy with AI, in fact, the dean at the School of Medicine in Pittsburgh asked me to give him one of our faculty to be the dean of AI. And our department has developed the curriculum for AI in our School of Medicine for the physicians this year. And guess which department, for the first time, I would say, since Virco a century ago, is now the most popular department with medical students? It is pathology, because we are the ones that have gone digital and are using AI, and all the medical students want to come to pathology and they want to be involved in AI projects. They never did before we started to do this. They didn't want to come and slouch over a microscope or go to the autopsy and smell a stinky corpse, etc. But this has changed pathology. So for hiring and retention, AI has been wonderful. I guess, as I said, it's still new for us, and the truth is how folks will go out using technology and train with our technology, we have yet to see. I do have one example where there's a huge shortage of cytotechnologists in this country. Those are the people that screen cytology slides like Pap slides. There are just not enough of them, and the schools have been closing down in the country. So maybe since we're going to primary screening with HPV, it's a good thing in that way, because there will be no cytotechs to screen. And as a result, some schools have had to train cytotechnologists completely digitally and remotely, like the University of Nebraska. So they have a cytotechnology school. It's all digital. It's all online, remote, and they train cytotechs to screen and do Pap tests. And they have found that when those cytotechnologists graduate and then they go work in practices that are not digital and they have to actually screen the real microscope and glass slides, they perform just fine. So will that be the case with all of AI? I don't know. But as I said, I'd rather give the folks the tools to use than deny them the tools to use, because I think the benefits outweigh the cons.
So very interesting talk, and we all use now AI, and I'm getting impressed with ChatGPT. Every time I use it was dumb like 2 years ago, but now it's getting impressive. And I think the more data they have, the better the outcome and the predictability of all these things are. So technically for cancer work, National Cancer Database has all this information, SEER database has all this word, and none of the AI has this information because it's a proprietary or something. Rather than every institution building out their own AI with our own thing, technically the government and the Medicare and National Cancer Database put millions of cancer patients into a database with their age, their social characteristics, and all those demographics. That will be the most robust system, right, for the AI to predict and things. Is that going to ever happen, or is it government, so it's not going to happen? Or how's that field moving? Because instead of wasting all these resources we have on every institution to build the government or this data is the highest yield, right?
You're absolutely right in that you need the data. The data is the crude oil in order for the AI to refine that oil into gas for whatever project you want. So no access to the crude oil, you're not going to have good petroleum. So ChatGPT or whichever other GPT you have out there will only be as good as the data that it has access to. So if you, as oncologists, want a GPT to have access to that data to provide the correct answers or guidance, then the data needs to be available and trained on it. Of course, that opens up a whole lot of issues like copyright, which is why ChatGPT has been sued by certain newspapers, because they feel that even though it's publicly available, there's copyright ownership of that information and data. And we'll see how that pans out. What we have done, for example, for our own PIT GPT is we have built the GPT, and we have only trained it onto selected data sets. So, for example, to sign out hematopathology reports, we've taken the GPT and we've pointed it to WHO, various other classifications, articles, etc. And so now when you ask it a question, which is, I have a case with 2% blasts, hypercellular iron stains positive for seroblasts and a couple of things, it will go to that database and make your diagnosis, which is exactly classified correctly. And so we've been using it for a while. And in fact, we've seen it's pretty phenomenal that when we have a group of 10 hematopathologists argue about how a case should be classified, because there's 2 classification systems now, the GPT is correct, and it has been correct each time. But it's because we've customized it just to that database. But, we have to learn more about how these things work, because I'll give you this example, where we went to the TCGA database. So the Cancer Genome Atlas has 33,000 cancers with all the data available, including all the images. And we used an AI algorithm to subclassify lung non-small cell carcinomas, which ones were squamous, which ones were adenomas, and various varieties. And we were very proud of ourselves that at the end of the day, we were able to do this with high performance with the AI algorithm. But when we went back to look at what features, and when we tried to do a little bit of reverse engineering, what did the AI algorithm find to make the answer? Well, we were shocked to find out that the most important parameter to make that diagnosis was none of the features in the images, none of the metadata about the patients, etc. It was the file name and where the image came from. Johns Hopkins, in those regions, they have a lot of people that are smoking, so most likely it's the squamous cell carcinomas that came from that area. And so that's what it had learned. And so, we have to be careful about even these, biases we don't even know about. So, yes, ASCO can convince all the cancer folks to release all that data, but you're going to need savvy folks to make sure that you're actually pulling the right information and it's not hallucinating or making deep fakes even on that data. Good. All right, thanks, guys.
Sorry, one quick question. Do you have any concerns about ultimately what will happen to the workforce as a whole as we continue to develop all of this? Is this going to replace tons of jobs?
Well, I think, yes. As the chair, I cannot even hire enough people for the workforce. So, as I said, I don't have enough technologists, I don't have enough PAs, I don't have enough pathologists, etc. So I do think that it's the right thing to do is to use technology to automate, to better integrate, and to do all of these things. Is there a consequence that we may actually outdo ourselves of a job? Yes. That is why, as us, like Darwin, we need to adapt and change. If you're going to resist the technology to solve these problems, then all you will do is make yourself less competitive to your competitor who is using the technology, because that's where patients are going to want to go eventually. So my answer is, yeah, we need to adapt and use it, and just figure out that people's jobs have to change. So you'll have to change the way you practice, your workflow, how you see patients, how you counsel patients, how you manage them, which pathways you put them on using AI. Because if you resist it because you want to keep many more oncologists around to do it manually and satisfy their need to have paper in their pockets and walk around, then you'll just become obsolete compared to your competitors. In my opinion, it's just my opinion.
Thank you.
Okay, you're welcome.